Normally I'm giving this talk to a group of therapists, and I realize there are some patients here today. So I don't know if any of you remember way back when there was a Saturday night science fiction, or Saturday afternoon science fiction theater, and they would have these movies come on, and some of them had graphic scenes that had this like flashing thing so you could look away so you wouldn't have to see the gory stuff. So what I did in my slides is I put a little star down in the corner before the slide coming up that might have something that was, some people have a sensitive stomach or just really don't want to see some of these things, and I understand that, but I just want to give you that warning. So if you see the star, just know it's coming. All right, so who am I? Why am I here? Well, thanks to Sophie, I'm here, and I appreciate her invite to come talk to y'all. I started out as a licensed massage therapist, and then I got my certification in lymphedema therapy, and I went to work for Memorial Hermann, and I worked in the wound care center there, hyperbaric wound care center, so got a lot of experience with wound care in that setting. And thanks to Medicare, I went back to school and got my occupational therapy license, and have continued doing what I love to do, and I'm now working in private practice, and I work part-time at Houston Methodist Sugarland. So I'm also on the medical advisory board for ARIA Health. This is a disclosure. And so what I want to be talking about is some of the anatomy and physiology of wound healing process, the types of wounds that we see, the skin breakdowns that we see with lymphedema, signs and symptoms of infection, what is the difference between infection and inflammation, because some people aren't quite sure if, is it red because it's infected, or is it red because it's inflamed, and there are some differences there. Best practices for skin care, for skin cleansing with wounds, and appropriate dressings. And then some of the terminology that as therapists we need to be using in our documentation. So, as a therapist, when we do our complete decongestive therapy, one of the components of that is the skin care. It's a very critical part of what we do. We don't just do the massage and the bandaging and talk to you about garments. We really want to educate you on that skin care component because it's so important. So I call this one of the 5 spokes in the wheel. If one of the spokes is missing, then you're going to have a harder time reaching your goal in your self-care, and skincare is a vital part of that process. So, what do we know about skin? It is the largest organ of your body, and it makes up about 15 to 16% of your total body weight. So you could say, I'm not overweight, I just have heavy skin. It receives approximately 1/3 of the body's circulating blood volume. It has an acidic pH of 4.5 to 5.5. It helps to regulate your body temperature, prevent water loss, and it helps to maintain our structure. So, in case you didn't need those things you forgot from anatomy class, there they are. It's also home to a variety of flora that are affected by the things that we do during the day, bathing, what we eat, what's going on our skin. It's our first line of defense against these foreign invaders that our lymphatic system is there to help protect us against. So we're losing water throughout the day, approximately 1 liter, and it's called transepidermal water loss. This is happening throughout the day constantly. And this is also affected by different factors such as humidity, the temperature, time of the year, our moisture content, our hydration level. Aging skin also. This is a factor in our skin. It loses collagen, it increases our susceptibility to injury or other forces of pressure. So one of the reasons as therapists we have to focus on meticulous skin care because we want to decrease that risk of skin infection. We also want to focus on the importance of hydration due to that water loss and those factors affecting the moisture loss. And we also need to consider additional padding for aging skin. So the skin is made up of 3 layers. You have your epidermis, which is your the thin outer layer. The dermis, which is the thicker under layer, which is mainly where your connective tissue has the blood vessels, the lymph vessels, the nerves, sweat glands. The initial lymph collectors are beginning in this layer. And then there's the subcutaneous tissue, which is underneath these first two layers, and that's where you have a fatty layer. So this is usually what you're going to see when you pull up, we'll diagram the skin, showing all this stuff there, right in that level of skin there at the beginning is, you've got hair follicles, you've got blood vessels, we've got, there's a lot going on on this initial layer of skin. So anyway, in that picture with all those structures, something has been left out, and our physicians, our medical personnel are still learning and being tested on some of these old models of anatomy where the lymphatics have not been incorporated into what they're learning. So if you look at this picture, there's no lymph vessels there. They don't show it, it's not in the diagram. So there's a lot going on there. We're constantly exposed to pathogens such as bacteria, fungus, viruses, and without that immune system there, we're at risk for infection. So this is kind of busy. It talks about the skin microbiome. This is the whole environment of your skin. It has its own thing going on. It's affected by lifestyle and age and moisture. So when the integrity of this microbiome is impaired, this can lead to damage and a portal of entry for pathogens to germs again. So this is where it creates that potential for wounds, for inflammation, for infection. And so this is where we need to talk about, remember that we're talking about the microbiome, which is this environment that's susceptible to external, internal, and other factors. So on your skin, all of us, all the time, have bacteria, fungus, virus. They're there. They're part of what our skin is made of. So we want to avoid that skin trauma, burns, sunburns, chafing, cracks. All these different things can lead or be a potential opening or a potential for infection to develop, because any opening in the skin is a potential area for those bacteria, virus, things to get in and to become a problem. So we also need to think about things like medical adhesive related injuries, people who have to have medical devices on their skin, and when you take those tapes can sometimes be an irritant and increase the risk of infection. Inflammation or infection. On the LEARN website, the Lymphedema Education Research Network, there is a webinar or a talk by Dr. George Kedrite. He talks about cellulitis and wounds and what we need to know. And I really liked his talk because he really focuses on the risk factors of cellulitis. And it talks about wounds being a complication of lymphedema, the signs of inflammation, warmth, redness, increased swelling, pain. He says that inflammation typically presents on bilateral wounds. So in other words, if you have inflammation, you're going to usually see it, especially in legs, you're going to see it on both legs. But if it's an infection, usually you may see that just on one wound, and that's where it's going to require the immediate medical attention. So with all of these conditions, we still recommend compression. So is this inflammation or is it infection? Other things that mimic inflammation infection are venous stasis dermatitis, acute chronic dermatosclerosis. This is the skin changes that happens in the skin that's been affected by lymphedema for a long period. Any trauma-related inflammations, deep vein thrombosis, gout, or peripheral arterial disease. These can sometimes mimic inflammations or infections. So at first glance, you might think that this is a leg that has cellulitis. However, if you pull back and look at the full picture, you're going to see both legs are looking pretty much the same here. And our treatment for this would be to skin and wound care, debriding or debriding, however you prefer to say that word, and appropriate wound dressings. So with this patient, just using those things, the skin and wound care, the debriding of the devitalized tissue, and the appropriate dressings with the compression and the manual lymph drainage makes a difference within just a week and a half. That's just a week and a half difference. I feel like I'm clicking over slides too fast here. Okay, so our guidelines, this is a general list of skincare guidelines, and this can be customized to each person and according to your daily occupations, what you're doing during the day. So I don't want to read through this whole list. Most of these skincare guidelines you can find on the websites under National Lymphedema Network or the Learn website. All of these lymphedema organizations have really good outlines and guidelines for skincare. So we don't want to forget about nutrition, and I know later we're going to have a speaker talking about nutrition. What we put in our bodies is as important as what we put on them. Good nutrition will promote healthy skin and wound healing. There are companies who make special products that help with wound healing, that provide you enzymes and the things that you need to help the skin repair itself. So those are things that you can usually, if you have wounds and you're going to see a wound specialist, they may recommend a particular product. As far as over-the-counter products, there are a lot of different things for moisturizing and cleansing. My personal favorites are the CeraVe, Eucerin, Aquaphor, or the store brand equivalents to any of those. There are some lotions and creams that will contain artificial perfumes and dyes. Those can be irritating to the skin. There are lotions like Lymphedema that are specifically designed for lymphedema. They contain essential oils, but some people can also have sensitivity to those ingredients or to different scents. So, by definition, a wound is an injury to the body and from a particular reason that usually involves the breakdown of the membrane of the skin and damage to the underlying tissue. So this creates a disruption in the integrity of the skin, and we want to assist with that process of the healing. So you have a lymphedema evaluation and you have a wound. Now what? So our guidelines to wound care. We want the wound covered with an appropriate dressing and changes needed. We want that wound to heal faster, and it will heal faster in a moist environment. The function of the dressing is to provide that right environment to enhance promote healing. So appropriate compression will also facilitate wound healing with few exceptions. So the stages of wound healing, these are just the basic 4 phases that your body goes through if something has injured your skin. Your first is going to be hemostasis, where it's going to want to stop if you're bleeding. It wants to stop the bleeding. Then we move into the inflammation stage, proliferation, protein synthesis, and the maturation and remodeling of that scar. So I'm not going to spend a whole lot of time on these slides because that gets quite in depth in the process here. So there's a difference between acute and chronic wound. An acute one will go through this progression of that healing cascade in a more timely, uncomplicated manner, and it usually takes anywhere from 12 weeks, give or take. Examples are surgical wounds or traumatic wounds which have normally healed and closed. And chronic wounds, these are ones that fail to proceed through this order. They've gotten a little disordered, and they do not take that 12-week or less healing time frame. Examples of these are venous wounds, arterial wounds, pressure wounds, neuropathic, diabetic, foot ulcers. So, and what happens is they tend to get stuck in that inflammatory stage, that second stage of wound healing, and seem to not be able to get through that stage. So the normal process, you can see redness, you can see swelling, you may feel a little bit of heat, maybe feel a little pain. Abnormal signs are when you see continuing breakdown of the skin, bleeding, unusual drainage, increased pain, redness around the wound, the peri wound, or if you're running flu-like symptoms. These are definitely those symptoms that you want to go see your doctor about or go to the ER. Now the next slide, I didn't put a scar on this, but the next slide does have an open wound, so just careful. So this is a picture of an inflammatory process happening here. So we have a nice wound there. Some of the wounds we see associated with lymphedema are going to be the non-healing surgical wounds, radiation, cancer, trauma, venous, arterial, and diabetic. So the wounds are typically described according to how deep they are in the skin. Superficial thickness wounds involves only the epidermis. These can be bright pink or red. They heal rapidly through the migration of cells that want to cross through the wound bed to heal itself. Examples of these are minor abrasions, blisters, first-degree burns. Partial thickness is where you have a little bit more of the dermis, epidermis, portions of the epidermis, but there's no bone, tendon, or muscle exposed. These also heal by what we call epithelialization. This is where the way the wound heals normally in a normal healing process, you want those cells to migrate across the wound bed so that they close over the wound and contract the wound margins. These can be moist and painful, but typically you don't see any yellow tissue in these types of things. Some examples of these are blisters, second-degree burns, or stage 2 pressure injury. Okay, this next slide is a full thickness. This is where you have destruction of the epidermis, the dermis, and the subcutaneous tissue. There can be slough, eschar. These are wound terms for the exudate, the things that happen in the wound bed. These are things that we see as therapists. And I'm going to talk a little bit more about what these terms mean a little bit later. So we always want to be able to describe what we're seeing in our documentations as therapists. We want to have a descriptor. So there's an acronym called CODE, and it stands for color. What color do you see in that wound bed? Is it pink? Is it red? Is it yellow? Is it black? Is there an odor? How does it smell? Not that we really like to smell these things, but they do have an odor, and some particular bacterial infections have a very distinct odor. What's the exit? What does the drainage look like? What's coming out of the wound? Is it thin? Does it have a little blood in it? We want to be able to describe these things in our documentation. So besides the color, what percentage is there in the wound bed? Is it red, yellow, black? How much of each one do you see in those areas? So for granulation, what we really want to see, we would want to see, in a good healthy wound, we want to see this red tissue. And I'm using the pictures that I used to work with Dr. Caroline Fight, and she always used the pizza analogy. So we're using, hopefully nobody's going to be turned off of pizza after today, but we use this pizza analogy because it really does show you, it looks like pepperoni pizza. And when it's a nice red beefy color, that's what we want to see. So pepperoni pizza is good for that. So when we see slough, we see this yellowish stuff. It looks more like a cheese pizza there, but that's not so good. This is a mixture of serum proteins, fibrins, albumins, denatured matrix proteins, and collagen. And this is something we do want to get cleaned out of the wound bed for it to heal properly. So eschar is necrotic tissue. This is a dead tissue. Definitely want to help remove that, but there's also a condition, what's called dry gangrene. It can look somewhat similar to this, and those wounds we don't want to confuse. This is an area where it is, for a therapist, it's really important to maybe spend some time learning about these types of wounds and how they're treated so that you don't cause more damage than what's already there. So this kind of looks like anchovies, which I don't know very many people like this. So there's also a very distinct green color. We see this with an infection called Pseudomonas, and this is one that has a very distinct odor as well. So we always want to look too at the amount of drainage. This is one of the areas that we can run into difficulty as therapists is trying to contain the drainage. There are different levels of drainage. When we have somebody coming in that has a plastic bag wrapped around their leg, tied up with diapers inside, and they're leaving a trail dripping behind them, then we know we have a problem. We need to really find a dressing that's going to help contain that exudate drainage and get them into compression as soon as possible. So as far as what you see coming out of the wound, that's the serous. The serous drainage. These are terms that we use to describe what is coming out, what does it look like. Because it can indicate, if there's a level of infection possibly. There are some dressings that we use that can create a brown type of drainage, so we don't want to confuse those. It helps to know what's been put on the wound. If we take a dressing off and we see a color that we're not expecting to see. So sometimes we have to know, was there a dressing used there that may have caused that, like an iodine, like some of the hydrogels and iodines would leave this color. As far as the odor, we want to know if there is an odor, if there's a malodorous, bad. If it's a sweet odor, how strong is it? Is it more of a fecal odor? These can depend on where the wound is to. So again, you want to make sure the odor is coming from the wound, not from the dressing, because some of these dressings can have a little bit of odor as well. So on our assessment of wounds, we also need to document how long it's been there, what's the location on the body, where on the body is it located, the shape of the wound, and the size of the wound. So for the size, we use standard measurements of, as if you were looking at the wound as a clock. So 12 o'clock would be towards the head, 3 o'clock, so you have this directional guidance to tell you, okay, you're measuring from this direction to this direction, from 12 to 6 to 3 to 9. So typically you want to take a nice perpendicular measurement, and basically you're measuring from the widest part in each direction. So we use that clock as a reference. And also for wounds that have what we call undermining or tunneling, where you can see there's like a little lip underneath that wound there. That's called undermining, and sometimes the wound can continue down underneath the skin, so we have to measure those areas as well. So you have to use special things like a long Q-tip to be able to place it under there to determine how much further that wound is extending underneath the skin. We want to look at the wound margins, the edges. Are they attached? Are they not attached? Are they rolled, which is called a pivot? When you see that rolled edge. This also is a problem because it can delay the healing process. It kind of stops the healing process, stops that migration of the cells coming across the wound. Are the wound edges wet? Are they dry? These are things that we have to, or we should be documenting. What does the wound around the skin look like? Is it denuded, callous? Is it red? Is it dry? Is there skin overgrowing? Can you press into it? Is there fluid draining out of it? So denuded skin, this happens when there's a loss of the skin from exposure to urine, feces, body fluids, exudate, or friction. They can be calloused. We typically will see this in a diabetic foot ulcer. This is called a hyperkeratotic tissue. This means there's overgrowth of skin around the area. These types of wounds require a physician usually to go in and do some debriding, the scalpel, or sharpen to take away the skin so that the healing process can begin again. Undermining is where in the picture I showed you earlier, this is where the skin is kind of pulled away from the wound and there's actually space in there. We don't like to have empty spaces there. We want to have that filled in. When we do wound care, we're going to placing a dressing usually into that when we call it packing. We want to make sure that the skin is getting a chance to start to pull together and to heal. Excoriation is a fancy word for scratching. It's where somebody has been scratching or something has been causing some scratches in the skin. Some people have a nervous habit of picking at their skin or scratching at their skin. That again creates another potential for infection if you're breaking the skin. Induration. This is where there's an increase in the fibrous element of the skin around the wound. It creates a loss of elasticity or pliability in the skin. It gets very hard, that we call sclerotic. This can be a very challenging thing to treat for therapists. Hyperkeratosis. This is the thickening of the skin's outer layer, where there's an overgrowth of skin. This lower picture is showing the papillomatosis. This is where the dermal papilla, these are the projections in the skin, are being pushed out from the fluid. And lymphedema, we see this quite a bit. This is where the lymph fluid gets to a point sometimes where it has nowhere else to go. The lymphatic system is working so hard to get this fluid moving back where it needs to go, but sometimes the skin just can't accommodate the amount of fluid that's being collecting in the skin. And so it's going to go to the point of least resistance, which is the skin. So you have this leaking process that starts. We treat this by protecting the skin. You can see this. There's some dry skin around that area. We want to moisturize that, so we want to do some moisture management. We want to do some hydration, but we also want to compress this because compression is going to be a key component in reducing this particular type of thing that we see. The maceration, this is where the skin has become so moist. It's a prolonged exposure to moisture. It's kind of like when you're in the bathtub for a long time or a pool and your skin starts to get kind of soft and white. That's maceration. Tunneling is where there's areas between what may be two different wounds or underneath the area, the edges of the other wound. And then this can be a potential for abscesses to form. These are common in some surgery, deepest wounds, arterial wounds, and pressure ulcers. And we also want to document the temperature of the skin. Is it cool touch, longer touch? Is there pain? Is it acute, chronic? We want to have descriptors for the pain, describe the pain. If there is pain and the patient's coming in for treatment, we want to know, did they premeditate? Did they take some pain reliever before they came? Because sometimes wound care can be a painful thing, depending on the type of wound. How many descriptors will we need to describe this particular wound? There's a lot going on with this wound. There's hyperkeratosis, that's the overgrowth of skin around the wound. There's hyperpigmentation, which is the discoloring in the skin, darkening in the skin. This is from the red blood cells leaking out and dying in the skin, and it creates that we call hemosiderin stain. It's like a permanent tattoo. Epithely, this is where the edges of the wound are rounded over. Induration, this is where if you pressed into the tissue around that wound, it would be tough and hard. The drainage from this wound would be very malodorous. It would be what we call serosanguineous. It would be kind of clearish with a little bit of maybe bloody tinge to it. This wound has a lot of yellow slough in it, and the person would be telling me this is a 10 out of 10 on the pain scale. This is a very particular type of wound that not a lot of people would see. It's not that common. Being in wound care, I've seen it many times, but a lot of people aren't accustomed to seeing some of these types of wounds and will try to treat them just the same as, say, a venous ulcer or another type of wound. This is something a little bit different. It's a different animal. It's called pyoderma gangrenosum. This is they call it a rare condition, but I've seen it enough to say I don't think it's rare. But it can cause very large painful sores and most often develop on the legs. The causes of pyoderma are somewhat unknown. They think that is a disorder of the immune system. People who have this condition usually have an underlying inflammatory disease, maybe inflammatory bowel disease or arthritis. These people who have these autoimmune conditions sometimes are at higher risk for this. The treatment for this is somewhat difficult. It can be very challenging. As a therapist, we want to do the moisture management, we want to use a dressing that's very absorbent, but at the same time, because of the pain level, we have to use something that's very gentle, and that's not damaging to the skin. That can be a little bit of a challenge to find the one thing that they can manage to keep on, because these people cannot tolerate compression. I had one lady come to me that had been suffering with this for 5 years. She'd been to different wound care places, she'd been to different doctors, and everybody kept trying to debride this wound and trying to clean it up and trying to put these dressings on it. And the one thing about this particular condition that makes it worse is anytime you create trauma, it makes it worse. So they were doing all these things that were the opposite of what should have been doing. Now, what should have been happening, hopefully, and I hope we sent her in the right direction to a dermatologist who deals with people who have this condition. They need this word is hard to say, corticosteroids, daily doses of the steroids. It needs avoidance of trauma. They need to have a dermatologist or immunologist or a wound care specialist that knows about these conditions to help them with this, because it's a very, very tough condition to treat. It's a very tough condition to deal with. So here's another very difficult case. I'm showing y'all some of the worst of the worst today, so now you know what some of the therapists are seeing and what we do. The descriptors for this, obviously there's some hyperkeratosis, there's some overgrowth of skin, there's some hyperpigmentation, that's the discoloring you can see. There, you can't really tell in the picture, but there was a lot of lymphedema, a lot of drainage here, a lot of macerations, and very malodorous drainage as well. I've seen a handful of these people as well. This is not a common condition, but in wound care we have seen it quite a bit. So the term we use for this is elephantiasis. That's the term we use to describe a body part that has become enlarged or disfigured because of the edema and the fibrosis that's happening in the skin. It is very difficult to treat. What I was able to do with this patient was that I used a disposable multi-layer compression system that is, usually has 3 to 4 layers, and that helped to reduce the odor, it helped to reduce the drainage and everything. That condition was called elephantiasis nostril-varicosum. It's a mouthful. I had a physician that sent me a patient, this particular patient, and didn't know what this was, and I texted him back and I said, "This is what it is," and he said that sounds Italian. So it's like, well, yeah, it's Italian for very fibrotic edema skin. So this is also a rare form of chronic lymphedema that can cause this progressive, what we call cutaneous hypertrophy. So that's that overgrowth of skin. And this is a gravity-dependent condition. It's usually in the lower extremities. And again, it can be very, very difficult to treat. We want to use super absorbent dressings under compression. Some really good wound cleansers. I would definitely recommend a pneumatic compression device, a pump, and I would recommend inelastic compression, something that's going to give this patient high containment to help reduce and manage and help him control at least or the drainage. Once we got that drainage cleared up, him and his wife were ecstatic because she was having to clean their apartment every day because of the drainage. So the wound infections, these can prolong in the inflammatory stage. It totally disrupts the wound healing. So if a wound culture is done, a tissue culture, they're looking at trying to find a certain amount of organisms that are growing in that tissue to validate whether there's actually an infection there. So those classic signs, again, are the pain, the redness, the increased swelling, the warmth, and the drainage. So those signs may not be present in people who have chronic wounds or people who are immunosuppressed. So there's an acronym to remember everything. So in wound care, we have one called NERDS. This is more for the superficial infection. So it's going to be a non-healing wound. There's going to be drainage, exudate. There could be some bleeding, some debris on the wound surface, and it can have an odor. The deeper infections, typically you're going to see a wound that keeps increasing in size. The temperature around the wound could be increasing. If you're probing into the wound, this could go deeper, like to the bone. There could be more areas of breakdown around the initial wound. There could be more drainage, more odor, more redness, more swelling. If the therapist is treating somebody and you're seeing these changes happening, it gives you an indication that there's a deeper infection. So this is another one of these conditions that make it difficult in wound care because wounds can develop this layer that kind of is impervious to what you're doing, trying to do to heal it. We call this biofilm, and this is where you have this overload, this overgrowth, this coating that is an aggregation of different bacteria. And usually to help correct this problem, it's going to be some debriding, some cleaning of that wound, some antimicrobial therapy. And usually if you see this in a wound, it's going to have kind of a slimy type of appearance. So the wound cleansers, there's a lot of different wound cleansers out there. My goal is not to go into all the different ones that are available, but just know that a good wound cleanser is really important because it does reduce help you to clean out that dead tissue. It makes it more effective in the healing process and to reduce the contaminants in the wound. One of the things I always try to encourage people to not do is to use hydrogen peroxide on the chronic wounds. That may be good for initial trauma to help to reduce the bacterial load, but it can be damaging to the tissue over time. Alcohol can be the same way. You don't want to use alcohol or peroxide on chronic wounds over a long period of time because it's not good for the healthy cells. It can damage those. So there's a lot of good commercial wound cleansers, and I'm always recommending if somebody's coming in to see me and I haven't seen a wound specialist, I try to get them in to see a doctor who can specialize in wound care. So for the debridement, this can sometimes be a little bit of an uncomfortable thing because you're rubbing on a wound. And you don't want to rub so hard that you're creating more damage. So one of my favorite products, and one of the vendors here has this product, it's called a Debrasoft. It comes in a stick with they call it a lolly, kind of like a lollipop, but it comes in a pad also. But this is a very gentle debriding product that I don't usually have very many people complaining when I use it, but this helps to remove a lot of the junk, what I call this the junk. This is getting the junk off of the wound. The infected tissue, the dead tissue, the fluff, all that stuff that needs to come out of it to help the healing process. So if you go back downstairs, make sure you see the walkthrough. Types of debridement. So there's different ways of removing the tissue from wounds. There's surgical debridement or what we call sharps debridement. This is done with a scalpel or scissors, forceps, and a curette. Autolytic means that you're using some enzymes to help soften and remove that tissue. The mechanical is where you're actually using something to work on the wound. That kind of describes itself. Pulse lavage is a tool that uses a water spray that has certain pressure between wounds. Hydrotherapy is not so common, I don't think, anymore. They used to put people in I know PTs would have these tanks you put your legs in and they do hydrotherapy. I think we've kind of gotten away from that so much. And wet to dry is, in the wound care world, we kind of consider that archaic because it tends to damage the wound every time you pull this dressing away, but sometimes it does serve a purpose to help you breathe. if you're squeamish and you're in a clinic where they use maggots, that is something that is very, very effective at breaking down dead tissue. There is a maggot therapy that actually have medical maggots that you order to put into things. Enzymatic debridement is where you're using usually a product that stays on the wound for a while to help soften and remove dead tissue. So is anybody overwhelmed yet? There's so much, and you can talk about wound care for 3 days because there's so much involved in wound care. So our objectives with wound care, we want to prevent and manage infections. We want to cleanse the wound. We want to maintain the appropriate level of moisture to help it heal. We want to eliminate dead spaces, control the odor, minimize pain. We want to protect the wound and protect the skin around it. So we want to choose dressing. This is kind of the mantra in wound care. If it's dry, make it moist. If it's wet, make it dry. If it's necrotic, you want to debride it. If it's irritated, you want to soothe it. So it's kind of this Goldilocks. You don't want it too much, not enough, too little enough. It's kind of right in the middle, just right. So the function of the dressing is to provide the right environment and to enhance the comeuppance healing. So when it comes to trying to decide on a dressing to put on wounds, it's going to be determined, number one, by the site of where the wound is, the amount of exudate, the amount of drainage it has, where is the wound in the process of healing, what's the surrounding skin look like, what is the patient able to do, what can the person do this wound care on themselves? They're going to have some help. Is there someone available to help them? And then sometimes cost and reimbursement can drive the decision when dressing choice. So the properties of wound dressings to use under the compression wraps that we use in therapy, we want them to maintain a moist environment and be able to handle that moisture without leaking out further underneath the bandages. So we want to make sure that it absorbs and retains that fluid under the compression bandage. It helps to be low profile because you don't want this real thick wrap bandage underneath a wrap that can create more pressure. You want it to conform to the wound bed. You don't want it to stick to the wound bed. So, we're looking for this perfect thing to put there. We want it to be comfortable. We want to make sure it doesn't cause further trauma, that the person won't have any allergies. Some people, we use silver dressings in wound care, and some people have a sensitivity to silver. It can cause a burn. We want to make sure that the wound remains intact when we are removing the dressing, that we're not creating more damage to the wound. And is it cost effective, and can they wear it over a period of time? So dressings, what's in your closet? If you don't have the advantage of working in wound care center and you have to find something to use, there are some lesser expensive alternatives to certain things that we're using in wound care. So a primary dressing is what we want to apply directly to the wound. A secondary dressing is what we would place over that to secure it or provide further protection and your therapeutic function. So there are, I don't know, I haven't counted, there's a ton of dressing categories. There are a lot of different dressings out there. But when it comes to lymphedema, we typically have our go-tos because usually what we're trying to do is control moisture and control drainage. So we use foam dressings. These dressings can have a silicone border that's a little bit more protective of the skin. They're absorbative. They can adapt to the contours of the skin. They help maintain that moist environment. And these can be used for a moderate to heavy exudating for anyone. Other things like non-adherent contact layers. There's a product called Adaptive. It looks like gauze with yellow substance in it that is a petroleum-based emulsion. And this can allow drainage to pass through. It's an antimicrobial type of dressing. Zero form, that's zero form I'm talking about, sorry. Adaptive is the one, the white one on the bottom. It's clear. It has no extra additives in it. We usually want to look at some antimicrobials, especially with wound care, because again, we're always concerned about controlling infections. These are some of these other microbials that we use. A composite dressing can be used as a primary or secondary dressing. This is usually a combination of several types of wound dressings in one product. These are really handy to have if you can get a hold of them. Sometimes if you can't get these wound products and you just need something, you can use baby diapers or sanitary napkins, pads. Those are very good at absorbing. And so those are sometimes recommended if somebody can't see a wound care specialist, they can't get wound care products immediately. We'll say, but get some baby diapers, go get some sanitary pads. Those will do in a pinch. Sometimes they're less costly. Super absorptive dressings are really important in lymphedema therapy for really draining, highly draining wounds. You don't want to cut these dressings because I don't know if you've ever cut a baby diaper and those little beads cut out of it. You don't want that getting into the wound. So you do need to be careful if you do these baby diapers. Don't cut them. Just make sure they stay intact. So some of the, what I call the supporting actors in wound care. There's a cloth that it's impregnated with silver and it helps to rip away moisture from areas, usually in skin folds where we see fungal infections a lot of times. The barrier creams are really helpful for the skin around the wound that can get really wet and macerated. Those are usually a zinc-based type of product. Moisturizers are important for the really dry skin to help moisten and protect that skin barrier. And then compression. Always compression. That's our specialty. So here's a case study using that silver impregnated cloth. It's called this one happens to be intradry aging. This patient had a very macerated foot where they were wrapping the foot, but all the drainage kept going down to his feet, and the bottom of his feet they were soft and wet, and it really needed to be dried out. So what we did, this was a kind of experiment we tried. We took that cloth, we brought it across the bottom of the foot, pulled it up through the bandage, and with this cloth you have to leave a little bit of what we call a tag hanging out so that it can wick out to the air. So I call it the mini pearl technique, where you have a little tag hanging out. So it helps to wick that moisture out from the skin. So this was him before we did it, and this was a few weeks later. So it dried the skin up really nice. So here's another case study with a lady that she was post-mastectomy. She had a squamous cell biopsy on her affected arm. They did a skin graft and it wasn't healing. So we applied a non-adherent dressing with a little bit of padding, absorbent padding over that under the compression bandage. And within a few weeks, it did heal. It looked much better. Now you do have to be careful. Like you can see in the first picture, there's a circle around the area where we used one product that was didn't have a dual border type on the dressing, and it tore her skin. Certain people have that propensity to have skin tear very easily, so you do have to watch what dressings are being used to protect the skin. So this was a patient with some venous ulcers that he was referred to the clinic for over 6 years. He had been unsuccessful with using compression stockings. He had recurrent cellulitis. His goal was just to wear shoes. He just wanted to get into his regular shoes. So what we did was, of course, we used a moisture barrier around the area where there was a lot of drainage. As you can see, there was a lot of maceration, that white in the skin. We used a silver dressing over that as a primary. And then I used a product called Drawtex, which is a super absorbent dressing on top of that. So we have an antimicrobial and a super absorbent within the same dressing. I experimented with him too with some other things. I had another product I was trying out called the Demaware, and this is a stockinette material that's securing the dressing, but it also works, and you can't tell, I don't know if you can tell by looking at his skin. He had very indurated skin. It's very hard, very fibrotic. it just, you touch it and it just doesn't move. It wouldn't move at all. So I used this over the dressing and underneath the wrap to act as, if any of you are familiar with foam chip, the nighttime sleeves of the foam chips, it creates this uneven pressure, and what it does, it acts like a micro massage in the skin underneath the wrap. So using this, I was able to soften up the skin to get better mobility, to get better lymphatic flow, to help with the Here we are at the beginning, and then towards the end of his therapy, where you can see there's a really good reduction, good wound healing. Something else I was going to mention about. I've actually got him into some inelastic compression, which is the Velcro wrap. Now he had difficulty, he needed help with the lower part, but he could independently do the knee wrap and the thigh. And his goal program shoes, he was able to get his shoe fine using this particular product. For therapists, we always are looking for things to help us do what we do better. And you have to say, well, what do we need? You know, you can be like Steve Martin, you jerk, you know, all I need is ashtrays, remote control, is Calvin, that's all I need. Well, we need our wound cleansers, we need wound dressings, we need compression wraps, and sometimes we need a whole team of professionals. We need team players. I don't know if you can read that in here, it's really light. We need maybe an infectious disease doctor that we can refer to. We need wound care specialists. We need podiatrists to look at foot issues. We need dermatologists to look at skin issues. We need vascular surgeons to look at the vein issues. Sometimes we need a rheumatologist to look at some autoimmune condition that's happening, that's maybe contributing to the wounds that are happening. You always need a certified inconvenient therapist on the team. We may need a board certified plastic surgeon. We need dietitians, nutritionists. And a lot of times we need a psychologist or psychiatrist, people who deal with these conditions for long term. It's very helpful to have somebody who can help them process through the mental part of all of these things that have to be done on a daily basis. That's the one question we get. Does this mean I have to do this forever? Well, we're not changing the reason that this is happening. We're giving you the tools to control and manage what is happening. And unfortunately, we don't have a magic wand to say, poof, it's gone. So it's learning how to deal with these things over time that some people really will need some help with. And I hope I'm doing okay on time because this is my last slide. So thank you for your attention.